Good afternoon, friends. I am Dr. D.K. Naik, Honorary Secretary of All India Ophthalmological Society. Welcome to the next edition of webinar, and today's topic is age-related macular degeneration, because we know this problem is a major problem. It's coming up because of the increasing survival rate in India, and also this problem is now being recognized very easily because of the various investigative modalities. Fortunately, we have some treatment now available which was not there about 15 years back. So because of so many new developments, today's topic is going to be discussed by Dr. Gaurav Shah, who is a retina consultant and trained in Shankar Nethralaya and L.V. Prasad Eye Institute, and he is attached to his own setup hospital and some other hospitals also, like Leelavati Hospital and Eye Life in Khar, and he is also the courtesy of research assistant professor, University of Florida, Jacksonville, USA. So without wasting any time, now I will invite Dr. Gaurav Shah to take over. Welcome, Dr. Gaurav.
Thank you, Dr. Naik. Very good afternoon, dear colleagues. As Dr. Naik rightly said, age-related macular degeneration is now into prominence, not only because of the increased incidence and prevalence, but also because we have options to treat them. So let's start directly onto the topic of age-related macular degeneration, or AMD or ARMD as it is popularly called so. AMD typically affects people over the age of 50 years, and it presents with macular changes in form of either pigmentary changes, drusen, geographic atrophy, or the presence of a choroidal neovascular membrane. One thing to be kept in mind is that there should be no other obvious cause for the pathology, such as myopia, inflammation, or angioid streaks, and in case there is myopia, then we need to be clear whether the choroidal neovascular membrane is due to age-related disease or due to myopia. The prevalence of AMD is increasing with the increasing age, but we still do not have an exact understanding of the etiology of how does the disease begin. If we look at the various prevalence studies and we look at the pooled data from studies which are done in 3 different continents, then the Beaver Dam study, the Rotterdam study, and the Blue Mountain Eye study showed that the prevalence of age-related macular degeneration is around 1.63%, out of which geographic atrophy is present in about 0.5% and about 0.9% patients have, or population has, neovascular AMD, or the presence of what we call as choroidal neovascular membrane. Let's have a look at the Indian scenario. APED's study from Telangana and Andhra Pradesh showed that the prevalence of any type of AMD in the general population was about 0.02%, while the study done in Tamil Nadu showed that when we look at the specific age group, then in the age group which is more than 40 years, as the age advances, we see that the prevalence of the drusen increases from 0.7% to almost 4.5% in people aged more than 70 years. Geographic atrophy similarly is present in about 1.1% of patients, and exudative age-related macular degeneration, or CNVM, is present in about 0.035% of the general population. Besides age, which is a definitive risk factor, the other risk factors show that there is female preponderance for age-related macular degeneration. As we saw, compared to the global data, the prevalence of age-related macular degeneration is lesser amongst the Indians and the Asian population. Systemic diseases like systemic hypertension and usage of tobacco in the form of smoking is shown to be a definitive increased risk factor for AMD. Ocular features like a light colored iris, refractive status of hypermetropia, or history of cataract surgery increases the risk of a patient getting age-related macular degeneration. Compared to those which were non-modifiable risk factors, we now look at those risk factors for AMD which can be modified. Cigarette smoking, systemic hypertension, hypercholesterolemia, diabetes, alcohol consumption, obesity, exposure to ultraviolet radiation, and atherosclerotic cardiovascular diseases are some of the risk factors which can be modified to reduce the prevalence of age-related macular degeneration. The most important which has been shown has been the history of smoking, and the pooled data from the 3-continent study showed that current smokers have more risk of developing exudative age-related macular degeneration rather than the dry type of geographic atrophy, while an ex-smoker retains a reduced risk but an equal risk of having both the dry and the wet type of AMD. Now, suppose if a patient already has age-related macular degeneration of the wet type in one eye, what is the risk of developing CNVM in the other eye? And this is based on the presence or absence of risk factors such as presence of more than 5 drusen or presence of one large drusen which should be of the size of more than 64 microns. And how do we calculate 64 microns? That is the size of the retinal vein at the optic disc margin. So when we look at the fundus at the optic disc margin, the size of the vein is approximately 64 microns. Focal hyperpigmentation and high systemic blood pressure. When with the number of risk factors increasing, it increases the risk of developing choroidal neovascular membrane in the other eye within 5 years. Going back to the anatomy, we can see that this is a animation showing a cross section of the retina in the macular or the foveal area. At the bottom is the retinal pigment epithelium. There is a Brooks membrane, which is the junction between the retinal pigment epithelium and the choriocapillaris in the choroid. The retina receives nourishment and oxygen from the choriocapillaris, which comes into the retina, and on the opposite side, retina disposes the waste material and the fluids from the retinal tissue into the choriocapillaris through the retinal pigment epithelium. Now, there are various theories about what leads to the development of age-related macular degeneration. The traditional theory talks about RPE senescence, that is, aging of the RPE cells leads to decreased function and hence incomplete degradation of the photoreceptors. This incompletely degraded photoreceptor material accumulates in the retinal pigment epithelium cells, which then form drusen, and this drusen further cause dysfunction of the retinal pigment epithelium, further leading to calcification and break in the Brooks membrane and development of a choroidal neovascular membrane. There is also a vascular theory which says that increased lipid deposition leads to scleral thickening, a reduced choroidal perfusion, and an impaired retinal pigment epithelial function, which essentially starts the cascade of RPE dysfunction. there is a genetic theory because 16% of age-related macular degeneration cases have shown a defect in the ABCR gene, which encodes for the retinal rod protein. And oxidative damage theory talks about the oxidative damage which occurs to the retinal pigment epithelium, and this particularly affects the central part of the retina, that is the macula, and this is supposed to be because there is no retinal oxygen supply to the central foveolar area. This area receives oxygen only through the choriocapillaries, and hence there is more anaerobic glycolysis here. To prevent from the disease of age-related macular degeneration, nature has provided this area with enhanced macular pigments in the form of lutein and zeaxanthin. Age-related macular degeneration is classified into the dry type or the non-exudative and the wet type or the exudative. When we look at the dry type, it essentially starts with the presence of drusen, which is nothing but small discrete yellow-white bodies which are present at the level of the retinal pigment epithelium. This can sometimes be confused for hard exudates which occur in vascular retinopathies like diabetic retinopathy, and the way to differentiate the two is hard exudates occur within the thickness of the retina. So while examining the retina stereoscopically, usually on a 78D examination, we can see that the drusen are much deeper. Like here, if you can visualize, we can see the blood vessel running over the yellow spot, and hence we know that this yellow lesion is in the deeper part of the retina or below the retina, and hence this is a drusen. Also, most of the drusens have a discrete border, unlike hard exudates which are more fluffy. On histopathology, these are colloidal bodies which occur beneath the retinal pigment epithelium. There are various types of drusen, the commonest being the hard drusen, which are usually smaller in size and have a very discrete or distinct border, versus soft drusen, which are usually larger in size, and it is often the multiple soft drusen which is a high risk to cause transformation to the wet AMD or choroidal neovascular membrane formation. One can also have the calcified drusen or the extremely large drusenoid PEDs or the drusenoid pigment epithelial detachments. Now, this animation shows that when there is a large drusen or a drusenoid PED, this further impairs the transport of nutrients to the RPEs from the choriocapillaries, and this causes elevation of the fovea and loss of vision. This presence of the drusenoid PED further keeps on increasing the problem of the health of the retinal pigment epithelium, and hence causes the vicious cycle of increasing the size of the drusen as well as decrease in vision. If the disease progresses further, then the drusenoid PED causes death or apoptosis of the retinal pigment epithelial cells, and also secondary changes underneath it leading to the damage to the choriocapillaries, and secondary changes above it to the outer retina or the photoreceptors. So essentially there is loss of retinal pigment epithelium, choriocapillaries and the outer retina, leading to formation of geographic atrophy. So this geographic atrophy itself is responsible for severe visual loss in about 25% of patients, of everyone who has a severe vision loss. This is how a geographic atrophy would look like on an infrared image, and when we do the OCT, then we can see that there is absence of the outer layers of the retina on the OCT. Even the thick red line responsible for or reflected from the retinal pigment epithelium is actually depressed or absent in the central area, and because there is no RPE here, we can see enhanced reflectivity of light from the deeper layers, that is the choroid. What has now been learnt is the role of VEGF or vascular endothelial growth factor in the etiopathogenesis of AMD. Drusen, as we saw, leads to reduced oxygenation and nutrients reaching the RPE and the photoreceptors, leading to ischemia, and together the combination of presence of drusen and ischemia leads to a situation where the RPE cells start liberating vascular endothelial growth factor. The vascular endothelial growth factor is a potent stimulus for the formation of new blood vessels, and also it liberates inflammatory cytokines which further disrupt the Bruch's membrane and allow the neovascularization or the new blood vessels to enter into the subretinal area, and this is nothing but what we call as a choroidal neovascular membrane. Let us see a small animation about the choroidal neovascular membrane formation due to increased VEGF.
VEGF, vascular endothelial growth factor, is a key regulator of blood vessel homeostasis. In neovascular AMD, an unknown stimulus causes the production of excessive VEGF. VEGF, released predominantly by the RPE, binds to specific VEGF receptors located on vascular endothelial cells. Binding of VEGF to its receptors is a powerful stimulus for angiogenesis, vasodilation and increased vascular permeability, release of proteases and other cytokines, as well as endothelial cell proliferation. The new pathologic vessels can break through Bruch's membrane, are friable, and are prone to leakage and hemorrhage.
So, as we saw that there is growth of abnormal choroidal vessels below the Bruch's membrane in the beginning, and then there is disruption of the Bruch's membrane and the new blood vessel gains access into the sub-RPE space and forms a network of blood vessels beneath the retinal pigment epithelium. The drusen which is present then gets resorbed through these blood vessels, and what is left behind is a network of blood vessels beneath the RPE. Again, because of the presence of vascular endothelial growth factors, there is liberation of fluid because these are leaky blood vessels, and fluid accumulates beneath the retinal pigment epithelium. The presence of a network of blood vessels with fluid underneath the retinal pigment epithelium is called as type 1 choroidal neovascular membrane. Subsequently, there will be a breach in the retinal pigment epithelium, and some amount of fluid will gain access into the subretinal space, which is defined as the space between the neurosensory retina and the RPE. On optical coherence tomography, one can see that in a type 1 choroidal neovascular membrane, the hyperechoic lesions are essentially present beneath the retinal pigment epithelium. If we can trace the retinal pigment epithelium, we can see that this lesion is predominantly beneath the retinal pigment epithelium. We also have the presence of fluid between the neurosensory retina and the retinal pigment epithelium, but the network of blood vessels is essentially beneath the RP, and hence this is a type 1 choroidal neovascular membrane. Subsequently, the vessel network also passes through the broken RP and reaches into the subretinal space, and we get what is called as a type 2 choroidal neovascular membrane. So if the network is present only beneath the RPE, it is type 1, and when it breaches the RPE and enters the subretinal space, we call it as a type 2 choroidal neovascular membrane. And we can see here that on OCT, if this is the retinal pigment epithelium, we can see that there is a breach in the retinal pigment epithelium, and the hyperechoic lesion is essentially above the RP, that means between the neurosensory retina and the RP. So this is a type 2 choroidal neovascular membrane. This classification into type 1 and type 2 was very important 10 years ago, when PDT was the essential form of treatment, because invariably PDT would be more successful in the type 2 CNVMs rather than type 1, whereas now with the advent of anti-VEGF injections, it does not make a difference whether it is a type 1 CNVM or type 2 in the prognosis. Similarly, if we see the fundus fluorescein angiography, which is a diagnostic tool for detecting presence of CNVM, and which was the mainstay of detecting CNVM before OCT came into vogue, then we will see that the type 2 CNVMs, that is the ones which are present above the RP, show hyperfluorescence early on in the form of a pattern, and then the hyperfluorescence keeps on increasing, showing leakage type of hyperfluorescence on the fundus fluorescein angiography. If this lesion is not treated in time, then eventually it keeps on growing in size, and at the end it will form fibrous tissue which is no longer exudating fluid, but a fibrous tissue which is very large in size and is preventing nutrition from reaching the photoreceptors, and this large fibrotic dried up tissue is what we see clinically as a disciform scar. So this is the end stage of the wet type of age-related macular degeneration, and this is responsible for 75% cases of significant visual loss in age-related macular degeneration. And on angiography, instead of the leakage type of hyperfluorescence, we will see that the dye is getting absorbed by the fibrotic tissue. That means the hyperfluorescence has distinct margins. There is no longer an active membrane but a dried up fibrotic disciform scar, which is not really amenable to anti-VEGF treatment. To summarize age-related macular disease, we see that they start with the dry type, that is the drusen, and some of them will progress to form drusenoid PED and geographic atrophy, which is nothing but the advanced dry AMD, while some will convert into the wet type and if untreated will eventually form disciform scar. How does the patient present? The patient in advanced stage may present with loss of central vision, but if the patient is intelligent, then he may present early on with history of distortion of lines, which can be checked on the Amsler chart. Also, since we know that this is a bilateral disease, it is important that every patient of age-related macular degeneration be given a home Amsler, that is a Amsler chart, to be taken home and to be read or interpreted daily or at least weekly unilaterally, so that if the other eye develops age-related macular degeneration, then in the early stages itself the patient will perceive distortion of line and patient can report back to the ophthalmologist for its management. Again, on fundus fluorescein angiography, we can further divide the type of choroidal neovascular membrane into classic and occult, and this had lot of significance when PDT was the mainstay of treatment, but in the present era where anti-VEGF is the mainstay, the importance of classifying it into classic and occult is no longer present. However, when we see that early on there is a presence of network of hyperfluorescence which increases towards the end, then this is classic type of choroidal neovascular membrane, and invariably this occurs in the type 2 variety. That means when the lesion is above the retinal pigment epithelium, and hence it is clearly seen as well on angiography. In occult choroidal neovascular membrane, one of the varieties is when there is a fibrovascular pigment epithelial detachment. That means the lesion is beneath or underneath the RPE. Hence, in the initial phase of angiography, we exactly cannot pinpoint where the lesion is, but as this dye advances, we can pinpoint the area of the pulling of the dye underneath the pigment epithelial detachment, and this is the occult type of choroidal neovascular membrane, which indicates that the lesion is beneath the retinal pigment epithelium, which corresponds to a type 1 lesion. Another way in which a type 1 lesion appears is late leakage of undetermined source. That means in the late frame we can see distinct leakage, but in the early stages we cannot pinpoint where exactly the leakage is starting from and resulting into the accumulation of the dye. Again, this is a patient who has, we can see there is a presence of a choroidal neovascular membrane and a hemorrhage, and on the right side here we have the fundus fluorescein angiography, which shows us the presence of leakage due to the membrane, but there is obscuration of the surrounding part due to hemorrhage and also by the RPE possibly, and in such cases an ICG angiography will be able to pick up the hot spot. That means we can see hyperfluorescence on ICG angiography even underneath small amount of hemorrhage. Now, let's come to the treatment modalities. When patient has drusen, essentially we do not actively treat the drusen. There was a time in between when drusen used to be treated with the help of laser, especially when it is a central soft drusen which is accounting to visual loss of more than or equal to 2 lines. In such a case, in the surrounding periphery, we used to give subthreshold or just threshold, that means quite a low dose of laser to the retinal pigment epithelium, and this used to kind of proliferate the retinal pigment epithelium, or it used to enhance the effect of the retinal pigment epithelium, which is thought to absorb the drusen. This leads to the RP getting reattached to the Brooks membrane and improvement in the visual acuity. In such a scenario, what is done is we spare the central macular area, and in 4 concentric circles we give 12 laser burns in each circle. These are at a very subthreshold or just threshold power, so that we do not destroy the retina or the photoreceptors. And in the publication by Jeffrey Banner, he had shown beautiful reabsorption of the drusen as well as improve in visual acuity, and the publication has shown that drusen reabsorption took place in about 68% of patients treated with retinal laser, but visual acuity improved only in around 11% of such eyes, and specifically they showed that majority of the eyes which had improved visual acuity had central soft drusen and initial visual loss of at least 2 or more lines. However, we have seen that in majority of the patients we do not get such good results, and this is useful only when there is a central soft drusen, a large soft drusen right in the subfoveal area, which is responsible for visual acuity of more than 2 lines. In clinical practice, usually we do not find many such cases. What we get cases are of normal patients with extensive drusens. In this treatment, or trying to prevent it from progression to wet AMD, is the role of nutritional supplements. There are various studies which have shown the benefit of AREDS type of supplements, omega-3 fatty acids, lutein, zeaxanthin, vitamin B12 and folic acid. The major randomized clinical trial which has shown the scientific way of managing such cases is the age-related eye disease study, which had 4,757 participants, and the AREDS study used a very specific combination of drugs, and it showed that if the patient has early stage age-related macular degeneration, then giving these antioxidants has no apparent benefit. That means if there are only few small drusen, or even if there are extensive drusen but small in size, then there is not much benefit of giving the AREDS supplementation. However, the antioxidants and zinc is effective in preventing progression to intermediate AMD, from intermediate AMD to advanced AMD by a rate of 1/4, that is in 25%. So, to summarize, age-related eye disease study showed that the specific AREDS combination is useful in the presence of extensive intermediate size drusen, or if there is one drusen which is extremely large, and large here means more than 64 microns, or there is presence of geographic atrophy in one or both eyes, or in one eye visual acuity is impaired because of advanced AMD, and advanced AMD means geographic atrophy or choroidal neovascular membrane. So when we have patients who have advanced AMD or large drusen or multiple drusen, then we need to start such patients on the AREDS combination. One thing to remember is these antioxidants are contraindicated in patients who are smokers, because in such patients the use of beta carotene has a increased risk of lung cancer. Multiple other studies have also shown the beneficial effect of using antioxidants, except for the use of beta carotene, which is actually harmful or increases the risk of AMD, again in some studies. But the beneficial role of the antioxidants has been shown, such as Rotterdam study showing 35% reduction in incident AMD, or the use of omega-3 fatty acids being shown to be beneficial in the Blue Mountain Eye study as well as the AREDS report, and macular pigments like the lutein and zeaxanthin also giving a protective effect from the oxidative damage due to the UV light, and the carotenoids in the AREDS study showing definite improvement by the use of lutein and zeaxanthin rich diets. Again, the Blue Mountain Eye study showing that use of lutein and zeaxanthin reduced the risk of incident AMD. Now, the lutein and zeaxanthin was discovered much later than after the original AREDS study, and hence there was a lot of confusion as to what drugs or what type of antioxidants would be exactly beneficial to patients with dry AMD. So the National Eye Institute in USA conducted another randomized clinical trial called as the AREDS-2, whose report gave us conclusive proof as to which antioxidants are really beneficial. The summary of the recommendation is, when the patients are already on lutein and zeaxanthin, there is no additional benefit of omega-3 fatty acids. So omega-3 fatty acids can be removed from the prescription. Again, beta carotene has no added advantage, but is actually harmful for patients who are smokers, and hence what really benefits in preventing moderate AMD from transforming into advanced AMD is the presence of these four constituents, that is lutein, zeaxanthin, high dose of vitamin E, low dose of zinc, that is 25 milligrams compared to the 80 milligrams which was used in the original AREDS study, because the effect of both the doses is same and the side effects of zinc can be reduced by reducing the quantum of zinc, and the fourth constituent is copper of 2 milligram. It is quite a sad story that as of now in the market there are very few drugs which actually have the exact constitution as prescribed by the AREDS-2. Actually, there is not a single drug which has exact this combination. However, there are few companies which are manufacturing half the dosage of these constituents, so the patients can be prescribed these drugs in the BD dosage. What is also important is that all these micronutrients can be procured through the regular change in diet itself, in which one can have presence of egg yolk, fruits and spinach or green leafy vegetables. This has shown to present not only the ARED type nutrients and especially the xanthophyls, that is lutein and zeaxanthin, and omega-3 fatty acids, as we know, is present in fish, especially the seawater fish. So elderly patients and patients with high risk for AMD can be prescribed a diet rich in antioxidants. Let's go to the treatment of age-related macular degeneration of the wet type. That means when choroidal neovascular membrane is already formed, then initially the only treatment available was directly laser of the new blood vessels, which would not only destroy the new blood vessels but would destroy the normal retina as well and would lead to immediate central scotoma. Though in the long run the destruction of the new blood vessels would cause stabilization of the vision, but an immediate loss of vision was something which was unacceptable to both the patients as well as the treating doctors. There came the discovery of photodynamic therapy, in which a photosensitizing drug was injected and which would be preferentially lodging into the new blood vessels, and laser would activate the closure of these blood vessels. So photodynamic therapy would cause selective destruction of the new blood vessels without harming the photoreceptors or the normal choriocapillaries. This vasculature would then shrink, the elevation of RPE would reduce, and we can see on this angiography a pre-treatment leakage as seen by hyperfluorescence, which on day 1 itself has disappeared. It is not that this treatment was without any collateral damage, but considering that in the early 2000 there was no better treatment, this treatment was the choice for patients with wet AMD, because in this treatment compared to placebo they could at least stabilize the vision, and that means at least 60 to 80% of the patients would remain within plus or minus 3 lines of their original visual acuity, while those treated with placebo, majority of them would keep on losing visual acuity as time went by. And when a subgroup analysis of the TAP study was done, it showed that in the predominantly classic type of lesion, photodynamic therapy had a definite advantage over placebo, while this advantage was not found over placebo in cases of occult choroidal neovascular membrane. And hence in that era it was important to differentiate between the predominantly classic or the classic lesion and the occult choroidal neovascular membrane on fundus fluorescein angiography. For patients who could not afford the photodynamic therapy, there was the presence of transpupillary thermotherapy treatment, in which low intensity thermal energy was given. This low intensity thermal energy would essentially be absorbed by the blood vessels and would selectively prevent the photoreceptors from damage. However, various studies had shown that the effect of photodynamic therapy was also again to essentially stabilize the vision, but it would not lead to improvement in visual acuity, and in practical experience TTT could not match the results which one could achieve with a photodynamic therapy. Feeder vessel treatment was another form of treatment in which on ICG angiography one would need to identify the feeder vessel and directly treat the feeder vessel. That means we are obscuring or closing down the vessel which feeds the choroidal neovascular membrane. This required the use of ICG angiography, and we can see that pre-feeder vessel treatment and the dramatic improvement post-feeder vessel treatment on FFA. But for identifying the feeder vessel, one had to look at the early frames of ICG angiography, identify the feeder vessel, and go and treat that vessel directly outside the foveal zone, so that on the next day when we repeat the ICG angiography, we can see that the vessel is obliterated and it causes a shrinkage of the choroidal neovascular membrane. Again, whether the lesion was subfoveal, juxtafoveal, or outside the fovea, that is extrafoveal, had a lot of implication when we used to use therapies like laser and PDT, because it would determine how much would be the collateral damage to the central foveal area. This is again a classic example of a choroidal neovascular membrane, and on fundus fluorescein angiography we can see the network of blood vessels and the hyperfluorescence increasing from them with the cuff of blood which is subretinal. So this is essentially a classic lesion, a predominantly classic lesion, which about a decade ago would have been ideally treated by photodynamic therapy. Versus when it is an occult choroidal neovascular lesion, then even photodynamic therapy did not give good results, and these patients would have to be left to their destiny. A occult lesion would essentially appear either as a notched PED. We can see here there is a pigment epithelial detachment, but which is not uniform. There is a notch over there, well differentiated on the fundus fluorescein angiography, and on the ICG angiography we can see the white lesion or the hot spot, which is where the choroidal neovascular membrane is. So we had multiple types of treatments available for wet AMD, and as we said, the direct laser photocoagulation was shown in the MPS or the macular photocoagulation study that it caused immediate loss of vision, and this treatment induced loss of vision was not acceptable to the patient as well as the physician. Photodynamic therapy was essentially useful for classic CNVMs but not for occult CNVMs. Transpupillary therapy was for people who could not afford photodynamic therapy because the results were not as encouraging as photodynamic therapy. And one novel treatment which showed a lot of promise few years ago was the use of low dose radiation, in which a probe could be possibly inserted into the eye, and radiation could be selectively given directly to the choroidal neovascular membrane. However, even this treatment has not shown promise in terms of improving the visual acuity. Most of the eyes just maintained the vision which they had at presentation. That had led to the development of surgical management of age-related macular degeneration, in which one would either surgically remove the network of new blood vessels or evacuate the subretinal hemorrhage and move the fovea to a healthier area. So as we can see in this diagrammatic representation, one would induce a localized retinal detachment, elevate the retina, go subretinal, pick up the membrane, which is combination of fibrous tissue and blood vessels, and actually yank it and pull it out of the subretinal area. This again surgery would be limited to the type 2 CNVMs, or where the lesion is between the retina and the RPE, because if the lesion is beneath the RPE, then one would not be able to access the lesion unless one rips open the RPE also. Also, if there is a very large choroidal neovascular membrane, then it would be difficult to remove this whole lesion without damaging the photoreceptors. Again, macular translocation. Once we remove the subretinal neovascular membrane, then it lies on an unhealthy RPE, which again is not viable for the photoreceptors to live, and hence there is no visual improvement. So many brilliant surgeons of that time thought of leaving the membrane where it is, but just translocating the fovea, shifting it so that it comes to overlie a healthy RPE and receives the nourishment. However, the major change in terms of treatment of AMD occurred when we realized about vascular endothelial growth factor. As we saw in the animation, it was in 1989 that Dr. Ferrara was able to clone a VEGF, and that led to the development of anti-VEGF or medicines which would block the vascular endothelial growth factor. And the three drugs which started with were bevacizumab, pegaptinib sodium and ranibizumab. As we know, VEGF leads to development of new blood vessels and releases proteases, cytokines and other materials which help in break of the Brooks membrane so that the membrane can enter into the subretinal space. The first and foremost anti-VEGF was bevacizumab, which was originally invented for use against GI tract cancer, but it was thought that this is a very large molecule of 148 kilodalton and it would possibly not be able to cross the retina. So in that era it was given intravenous for GI cancer, and they had lot of systemic side effects. However, in 2005, Professor Philip Rosenfield from Miami showed in clinical studies that though Avastin is a 148 kilodalton molecule, when injected intravitreally, it showed efficacy in age-related macular degeneration as well as vascular retinopathy related macular edema. This is a diagram showing a Avastin molecule, and Lucentis or ranibizumab is nothing but a small fragment of Avastin. So when we have a smaller fragment of the active part, which is only about 1/3 the size of about 48 kilodalton, that is what exactly is Lucentis compared to a large molecule which is Avastin. And Lucentis was specifically invented for giving intravitreal injections every 4 weeks. We also had a molecule called as Macugen, which selectively targeted the VEGF A165, and at that time it was thought that this selective blockage would be blocking only the biologically most important isoform. However, time has shown us in practice that Macugen is not as effective or efficacious as Avastin and Lucentis in the management of choroidal neovascular membrane. So, a quick look at the studies. It showed that compared to the patients who received placebo and kept on losing vision, Macugen prevented that significant drop in visual acuity. This was the first drug which was licensed for use inside the eye intravitreally, and we can see some remarkable photographs of angiography of how a classic CNVM was obliterated with the use of only anti-VEGF drug. The best part about the use of anti-VEGF was that as compared to the PDT, which was the gold standard at that time, it not only worked against predominantly classic type of CNVM, but they also worked in the presence of minimally classic or the occult choroidal neovascular membrane. And hence, with the advent of anti-VEGF, we stopped looking actually into whether the CNVM is the classic type or the occult type, because irrespective of the type, the anti-VEGF would work against it. Lucentis came about 2 years after Macugen came into clinical practice, and when the studies compared Lucentis with or without photodynamic therapy against a placebo, it showed that it was not only effective in stabilizing vision, which was defined as loss of less than 15 letters at the end of a year, and if we see that not only did it prevent loss of vision, but we actually from the anti-VEGF use started talking about now gain of visual acuity, and show that the arm which used Lucentis had about 25% patients which had a gain of visual acuity compared to only 5 to 6% in the placebo group. And the mean change in visual acuity was approximately about 5 letters on the ETDRS chart, equivalent to about 1 line on the Logmar chart or the Snellin's visual acuity. We can go on and on about the various studies, but essentially while we came to the use of anti-VEGF in the eye, especially the ranibizumab, that is Lucentis, we saw that in 95% of patients we were able to stabilize the vision. That means there was loss of less than or equal to 3 lines in 95% of the patients when they started the treatment, and about 25% of them had actually an increase in visual acuity, which was unheard of before the use of anti-VEGF for such patients. However, most of these studies required that the anti-VEGF would be injected every month. That means every 4 weeks anti-VEGF would be injected into the eye, and this would continue on and on at least for 2 years. Practically, this was something which was difficult, not only because of the increased risk of endophthalmitis with injections, but also because the patients used to get tired of coming in for an injection every month. And hence, there were multiple studies which tried to give initial 3 loading doses and then space out the injections for maintenance therapy. This on the left are the Marina and the Anchor studies, which showed that compared to the group receiving placebo, those patients who continued to get intravitreal anti-VEGF or Lucentis every 4 weeks or every month not only improved visual acuity but maintained that improvement. Compared to that, when in the peer study, when they received initial 3 loading doses of monthly interval Lucentis, there was an improvement, but when they went into the maintenance phase, they did show a small drop in the benefit which they had achieved. Though this was definitely better than the placebo group, one can see that the maintenance of visual acuity was less compared to those patients who received monthly injections indefinitely. At the same time, many studies started coming out which showed the role of bevacizumab or Avastin. Though there was no major randomized clinical trial because there was no financial backing from a pharmaceutical company which could be there for Lucentis, and hence there was no major RCT. There were multiple small studies which showed equal efficacy and safety of Avastin or bevacizumab when it was given as a monthly injection. So, we are at a stage where the anti-VEGF treatments initially started as a fixed treatment regimes wherein they would be given every month, to options wherein we try to reduce the number of injections either on a PRN basis. That means initially first 3 months we give monthly injections of anti-VEGF, and thereafter we re-inject only when the patient has either a drop in visual acuity of more than 1 line or there is a significant increase in OCT thickness or reappearance of fluid on OCT. Versus in treat and extend, it is a system which is in between fixed treatment regime or PRN regime, in which we initially first 3 months give every injection at every interval of every 1 month, and thereafter we keep on extending the gap between injections. Once the patient has improved visual acuity and the OCT shows thinned out retina, there is no longer any edema, then we extend the gap between injections from 4 weeks to 6 weeks, then 8 weeks, 10 weeks, 12 weeks, till we reach a gap of maximum 3 months between any 2 injections. These are all been ways to try and prevent or reduce the number of injections and still try and achieve the good visual acuity which is achieved by the fixed treatment regimes. One word on the use of Avastin. Whenever Avastin is being used, we know that the economic advantage comes when a single vial of Avastin is used to inject many patients. However, it is very important that this formulation of small dose Avastin is done in a proper way, either in a biosafety cabinet or a operation theatre environment with gloves, wherein the samples of Avastin are taken into tuberculin syringes and packed again into sterile material and stored in the maintenance of the cold cycle is extremely important. In future, we look forward to gene therapy because of the presence of the ABCR gene in majority of the patients with age-related macular degeneration, and maybe the retinal prosthesis will become a reality in practical life, wherein patients with advanced geographic atrophy or disciform scar may be able to see with the help of the prosthesis. I acknowledge my alma mater and all my patients who have helped me learn what I know today about age-related macular degeneration. Thank you very much, and I would request all the people to please type in their questions for the question and answer. We will be able to read the questions and we'll try our best to answer them.
Now, before Dr. Gaurav is reading the questions and answering, I will just remind you that now, because of the Avastin problem which has cropped up recently, there are some guidelines which have been issued by VRSI and AIOS. So please go through those guidelines and follow those guidelines if you want to be safe and defend yourself in the court of law in case of some mishap happens, because if you don't follow the guideline, probably you will be in problem.
Okay, so going to the first question by Dr. Rahul. The question is, in polypoidal choroidal vasculopathy, that is IPCV, does PDT work better? So I presume when we are saying better, it is PDT versus anti-VEGF, and again studies have shown that even in IPCV, anti-VEGF has a good amount of visual benefit compared to the use of PDT alone. However, studies have also shown that when both are combined, that means in IPCV, when we use anti-VEGF plus photodynamic therapy, then we can reduce the number of injections and still give a better visual acuity compared to the use of PDT alone. We have another question from a very renowned retina specialist from the city of Cochin, Dr. Biju Raju, who is asking, what is my preferred treatment strategy, PRN or treat and extend? So my straight answer to that is, I prefer the PRN methodology, in which we monitor the patients on a monthly basis. When we are seeing the patients, we see not only the visual acuity but do a OCT as well, and if there is loss of visual acuity by one line, if there is increase in OCT thickness, or if there is reappearance of any fluid, then we re-inject the patient. Treat and extend, on the opposite side, requires that the doctor keeps on injecting the patient irrespective of whether the visual acuity has improved or decreased, irrespective of whether there is any change in the OCT thickness or not. And though some of the recent articles have shown a slight improvement in visual acuity with the treat and extend system, I still, as of now, I am more inclined towards the PRN, and patients also accept the PRN system much easily, because there is a OCT report which they can see, or they actually experience a loss of visual acuity and they are ready for the next injection. Dr. Saideep is asking when to decide to give laser treatment for drusen in age-related macular degeneration. So, for regular drusen or the hard drusen which are present, we should usually not go ahead I usually don't go ahead for a laser treatment, because there is no definite benefit which has been shown. We can see a definite benefit only when there is large soft drusen which is present subfoveally, and when this drusen is responsible for loss of visual acuity of at least 2 lines, because it's only in these cases that studies have shown that there is a benefit of gaining those 2 lines of visual acuity. Very good question by Dr. Pankaj Chauhan. Is there a product available in the market that follows the AREDS 2 formula? So, as I was saying, that unfortunately, and I really have not been able to find out why, there is not a single company which has been able to market antioxidants exactly as per the AREDS 2 criteria. I think it has something to also do with the high dose of vitamin E of 400 international units, which I believe is not permitted by the Drug Controller of India. But there are few companies which have created antioxidants which is exactly half the dosage of the AREDS 2 formula. Maybe if you can email me, I'll try and find out a compilation of which all drugs in the market have the exact half dosage of the AREDS 2 and let you know. Question by Harsh: how much increase in central macular thickness on OCT on follow-up requires re-injection of anti-VEGF? So, Dr. Harsh, when we are on the PRN system, then if there is loss of visual acuity by even one line, then irrespective of the macular thickness increase, we will re-inject. A second scenario where the visual acuity is stable, but if the macular thickness increases by more than 100 microns is when I would re-inject. And in some cases where the macula was completely dry, even if there is small reappearance of a pocket of fluid, even if the thickness has not increased by 100 microns, but a reappearance of fluid for me would be an indication to re-inject this patient. Dr. Parag Bagad has asked about the treatment for RAP. RAP or RAP is retinal angiopathy, and it is a type of choroidal neovascular membrane in which the lesion predominantly starts from the retinal vasculature side. As we saw in the animations, we were essentially talking of new blood vessels arising from the choroidal neovascular, from the choriocapillaries and coming anteriorly towards the subretinal space. On the contrary, in RAP lesion, the lesion starts from the retinal arterioles and goes underneath below the retina. So again, anti-VEGF works well even for RAP lesions, but since these are typically the type 2 kind of lesions which will show classic type of fluorescent pattern, even photodynamic therapy is equally effective in the treatment of RAP lesions. If we can also find out the origin of the RAP which is away from the fovea, then one can do a focal treatment like a feeder vessel treatment also to the RAP lesion. So in RAP, typically I again start with anti-VEGF injections, but if I find that the treatment is not leading to the shrinkage of the vessels or the number of injections required are many, then I give the option of adding photodynamic therapy to the patient in a RAP lesion. Dr. Silvasekharan is asking about the early ARMD treatment when vision is 6.5. So if visual acuity is 6.5 and if the patient has dry AMD, that is presence of drusen, then we would look into whether it matches into the AREDS criteria. That means if there is extensive moderate size of drusen or very large single drusen, or if the other eye has advanced AMD and visual acuity has been lost due to either geographic atrophy or choroidal neovascular membrane, in which scenario I would start the patient on antioxidants. If not, then I will give the patient a Amsler chart for home Amsler and regular monitoring on a daily basis. However, if it's a confirmed choroidal neovascular membrane which has been confirmed on angiography, yet the vision is 6.5 with history of wet AMD in the other eye, then even if the visual acuity is 6.5, I would not stop myself from advocating anti-VEGF injections. Question by Dr. Pankaj Chauhan is how long the patient should have quit smoking to be started on antioxidants. So studies have shown that even smokers who have quit and when they are started with antioxidants containing beta carotene, those patients are also at a higher risk of developing lung carcinoma. And hence, for any smoker, it is contraindicated to give antioxidants which contain beta carotene. However, as AREDS 2 has shown us that beta carotene is not really required when we have lutein, zeaxanthin, vitamin E, zinc and copper. Then in such patients we can use any other antioxidant which does not have beta carotene but has the 4 essential ingredients as mentioned in the AREDS 2. For how much time a filled syringe of anti-VEGF can be maintained in cold system is the question by Dr. Satish Kumar. Now, there are various ways we can tackle this question. So, how long can we maintain it? We can maintain it indefinitely. The question is, how long can that maintained one be used? Now, the way to look at it is in terms of efficacy. Suppose if anti-VEGF is maintained in cold system, and here essentially I think we are talking about Avastin which has been fractionated in a proper biosafety cabinet or operation theatre environment, then it doesn't lose its efficacy. Not only research has shown but even clinically, at least for 1 to 2 months, it has been seen that the efficacy of the monoclonal antibody is preserved when the drug is maintained in the cold chamber. The second way to look at it is, what is the risk of infection? Any drug which has been fractionated and kept, with time, the risk of infection always remains. And hence, many systems advocate that once the drug is fractionated, it should be used on the same day, or even if you are using it on separate days because of not having large number of patients on the same day, the earlier you use it off, the better it is. There is no definitive answer for this, but using a drug kept in a cold storage system of more than 1 month is something, in my personal opinion, would be a contraindication.
In this field, Gaurav, I just want to point out, I think as per the new guidelines which is created by VRSI and AIOS, whenever you fractionate it, probably it recommends that you have to send it for culture. Once you get negative report, then only you can start using it. It means the same day you cannot use it, you should not use it. So I am little confused. So whether it should be used on same day or it has to be kept, because if I remember correctly, as per the guidelines, it has to be first sent for culture, and if it shows negative, then only after 48 hours at least. So then it can be used. So maybe on that day you cannot use it.
I think the question about sending the first drug itself for culture is not to do much with the cold system, but to do with the authenticity of the drug which we are getting.
Yes, yes. So suppose from one vial you have made say 20, then even out of that 20, not even the first one also you cannot use it unless you have got that it is authenticated that it's not contaminated.
Yes. So that is there.
Yeah.
And also what some people do is, suppose if they give on a week basis, that means they opened it today, sent one to the microbiology department. Once they have got a negative report, that is there is no contamination, then they use it.
Yeah, this is what I was pointing out.
And again, next week when they are going to use it in the second batch, again they will send one more aliquot from that batch and confirm that there is no growth before using the second batch. Dr. Jyoti's question is, what is IPCV or idiopathic polypoidal choroidal vasculopathy? IPCV is again a type of choroidal neovascular membrane. This is more present in the Asian countries, especially Japanese population. When we were using photodynamic therapy, this was one recalcitrant type of choroidal neovascular membrane which was specifically not amenable to photodynamic therapy. It was felt that again, for IPCV to be diagnosed, invariably we require ICG angiography, which is able to detect lesions in the choroid. We typically see multiple polypoidal lesions at the choroidal level on ICG angiography, and this requires extensive treatment. One thing to remember also is patients with IPCV often tend to bleed quite a bit, and if these patients are on blood thinners or especially extensive use of low dose aspirin, then in consultation with the internist, one should try and stop the use of aspirin, because aspirin has been shown in patients with IPCV to lead to massive hemorrhage. If clinically you ever see a patient with hemorrhage in multiple levels of the eye, that means you see vitreous hemorrhage also, subretinal hemorrhage also, and sub-RP hemorrhage also, then think about IPCV as one of the differential diagnoses. Dr. Saloni Gupta's question is, how frequently should we follow up a patient of dry AMD? A patient of dry AMD, the follow-up is one part, and how do you follow up or what is done between the follow-ups is equally important. As I said, it is of utmost importance that the patient use a home Amsler chart, and if you tell them to follow it up on a daily basis, then invariably practically they follow it on a weekly basis. If you tell them to follow up or do the home Amsler on a weekly basis, then invariably they do it on a monthly basis or even forget it. So, for a patient who is educated, informed, and who listens to the doctor's advice and is regularly doing a home Amsler chart, once in 6 months is a good amount of follow-up. However, if the patient has multiple soft confluent drusen, which is again a high risk for conversion to wet AMD, then we would see this patient earlier, that is even every 3 monthly if required. Very intelligent question by Dr. Selvashekaran again. Can natural beta carotene be used by smokers? There is nothing which you and I can really do to such patients, because if a patient is smoking, I think the first advice for any patient who is having AMD or who is a high risk for AMD is to quit smoking. If the patient wants to continue smoking and still wants to know about the use of natural beta carotene, then no, we don't have any supporting evidence that whether natural beta carotene has any damage on the patients who are smoking or has a higher risk of lung carcinoma. But what has been definitely shown that when we give external high dose supplementation in form of 15 milligrams of beta carotene, then it has a higher risk of lung carcinoma in smokers. So smoking is something which should be one of the first things which you advise your AMD patients to stop. Dr. Parth Patel is asking that patients who cannot afford anti-VEGF, is there any role of intravitreal triamcinolone in wet AMD? Unfortunately, no. For at the present era, especially with the hard work of the AIOS committee and the VRSI, who have given us a guidelines and the clearance for use of bevacizumab, I believe the cost has come down dramatically, especially for the doctors who have high volume patients, wherein they are able to fractionate and use the drug into multiple patients safely. However, triamcinolone acetonide per se has not shown to be efficacious in wet AMD. I know in macular edema due to vascular retinopathies like diabetic retinopathy or branch retinal vein occlusion, triamcinolone acetonide is efficacious, especially in pseudophakic patients, but in AMD, where the pathways are very different for the occurrence of macular edema, IVTA is not an option. Okay. Dr. Parag Bagad has another two questions. The first question is the use of VEGF trap in AMD. When we talked about the anti-VEGF, we mentioned about Avastin, Macugen and Lucentis, which are basically anti-VEGF. That means they directly block the VEGF molecule, versus VEGF trap or aflibercept is a molecule which blocks the VEGF receptor. When the aflibercept trials were started, those were non-inferiority trials. That means we wanted to see whether the drug is equivalent in efficacy to Lucentis and whether we could reduce the number of injections, because the main issue with Lucentis was every 4 weekly injections. However, the trials have shown that aflibercept in the results are equivalent to the Lucentis. That means there is no inferiority of aflibercept. That means aflibercept is not inferior to Lucentis, and unfortunately the number of injections have not drastically reduced compared to the Lucentis. Clinically, the importance of aflibercept or Eylea comes when there has been a patient who has been on anti-VEGF and the patient is not responding to the use of Lucentis, or a patient whose macula had become dry, had flattened, but recurred, a lesion recurred, and this lesion is now not amenable to Lucentis. That is the time when practically we would try and switch over to a different drug, and here aflibercept or Eylea is a promising option. We don't necessarily use it as a first line drug, essentially because of the cost constraint in India. Again, the second question by Dr. Parag is when to opt for full fluence and half fluence photodynamic therapy in treating polypoidal choroidal vasculopathy. In my practice, I saw that when we were using full fluence PDT or the regular photodynamic therapy, we still used to get a lot of collateral damage to the photoreceptors and the surrounding areas, which used to prevent increase in visual acuity or might actually even decrease the visual acuity to some extent. That's when the studies showed that when the laser energy is half, that means when we use the half fluence photodynamic therapy, then efficacy is almost similar but the collateral damage is less, and hence even in IPCV, whenever I go ahead for photodynamic therapy, I prefer to keep it at the half fluence settings. Dr. Parth Patel is asking, what is RPE-RIP? The retinal pigment epithelium RIP is nothing but the tearing of the retinal pigment epithelium. What we have to understand is the retinal pigment epithelium, which is normally flat, in cases of choroidal neovascular membrane becomes elevated, especially in the type 1 lesion. Now, this used to often much more with photodynamic therapy, but sometimes occurs even with anti-VEGF, that when we give the treatment and the CNVM collapses, the vascular membrane reduces, then suddenly this RPE elevation is reduced, and this sudden change causes the retinal pigment epithelium to get torn at its junction, and the retinal pigment epithelium gets folded over itself. So there will be one part where the retinal pigment epithelium is in double layer, and the other part where the retinal pigment epithelium is completely missing. Now we know that retinal pigment epithelium is important for the health of the photoreceptors, and hence RPE-RIP or tearing of the retinal pigment epithelium is actually detrimental to the visual acuity. RPE-RIP can occur de novo, that is without any form of treatment also, but it can occur on use of photodynamic therapy or anti-VEGF as well. And typically when we see clinically in the area where there is infolding of the RPE, it will appear as a hyperpigmented or a brownish black part, and the area where the RPE is missing will be seen as a whitish lesion, and this will be accentuated on fundus fluorescein angiography. That means we will see blocked fluorescence where there is double layer of RPE, and we will see hyperfluorescence where the RPE is missing.
Thank you, Dr. Gaurav, because we had so many questions, and I am happy that all varieties of questions have come in, and everyone is taking advantage of this, and they were definitely listening very minutely. That's why they have asked so many questions, and you have really answered them very well, and I am sure you all must have been benefited by this. And so just before we end, I think Mr. Ashwin from Sipla just wants to make an announcement. You want to make some?
Hello everyone. It's a great pleasure that we have been given this opportunity to conduct these webcasts every Thursday since May, and I'm sure this is going to be continuing for a long time with several speakers coming in, many topics coming in. Really thankful to AIOS for this opportunity. I also take this opportunity to inform you that this month, September, is being observed by Sipla as Retina Month. As part of Retina Month, we have decided to conduct a lot of activities on the ground, of which one of them is Envision workshops. So Envision workshops is a type of a workshop that we conduct with retina specialists and general ophthalms. We invite general ophthalms in batches of about 8 to 10 to a retina specialist clinic, where the retina specialist can actually provide hands-on training on indirect ophthalmoscopy and OCT to the general ophthalms, and a healthy discussion on simple diagnostic techniques in retina, which also includes FFA, can be done by the retina specialist to the general ophthalms. So just wanted to convey the message that our entire field who is out there, they have all the details regarding this webcast, and the general ophthalms, specifically for the general ophthalms who are interested to learn more on retina diagnosis from retina specialists, please feel free to share your doubts or any clarifications that you might want on this with our field, and our field will be very happy to provide information on that. We have selected certain retina specialists across which the field will have information on, and we'll be happy to help you get connected with these retina specialists through these workshops anytime throughout the month or even beyond that. But what we are planning is to conduct maximum number of workshops this month itself. Thank you so much.
Thank you, Ashwin, and I think Cipla has really taken a very good step in this direction. That they are now so much in educating doctors. So really, I thank Cipla, and thank you once again, Dr. Gaurav, for to be here and lovely presentation. Thank you.
Thank you very much. I especially thank Dr. B.K. Nayak and the AIOS for organizing such a wonderful webinar series. Thanks a lot.